The arrow.
Yep, the arrow you show me there.
Or the point. Yeah.
Very good, very good. So thank you for inviting me. So my topic is non-invasive ventilation. My background, as you can see there, I do pulmonary critical care and sleep medicine, and I've been working in the States since 2009. Currently, as you see, I'm working at the Marshall Clinic System in Beaverton, which is an hour away from here. So disclosures, financial disclosures is none, but I do share that I'm preparing to take the sleep boards in November. So I've been studying and doing quite a few courses. One of those is the chest sleep board review. Many of the slides that you're going to see are coming out of that course. The other one is a sleep medicine trends from the ASSM, where the slides are coming from Dr. Wolf from Northwestern in Chicago. So the outline of the talk is first go over clinical definitions of what hyperventilation is. My experience through different labs in the state and in other states is that most of our technicians are or were more concentrating in doing sleep apnea diagnosis and treatment. As you've been hearing the whole day, now we're seeing more hyperventilation, and I think a lot of the in-lab works come through those lines at this time. Then I'm going to discuss as briefly as I can the two most common conditions of hypercapnia or hyperventilation, obesity, hyperventilation, and COPD that tend to be more commonly seen. Different NIV modes and devices trying to tailor for the in-lab titrations or downloads that you can see in the clinic in order to optimize compliance. And then hopefully we have some time for final remarks. There's been a lot of discussion from the mostly pulmonary societies trying to advocate on our behalf to Medicare in order to change the different rules where patients can get NIV devices for outpatient treatment. Unfortunately, those are just at this time comments. Medicare has not made any major decision about those, but it's important that we are aware of those. So the first thing is the definition of hyperventilation, and most of you know we need either one of these two instances. The arterial PCO2 or the surrogate is more than 55 millimeters of mercury for more than 10 minutes, or the PCO2 increases more than 10 during sleep compared to awake to a value that is more than 50 for more than 10 minutes. So this is the current ASSM diagnosis of hypoventilation. Of course, the surrogates, as you know, is the transcutaneous CO2 and the end-tidal CO2. Way in the past, we used to think that hypoxemia, persistent, not responsive to CPAP, probably was related to hyperventilation, but that's not what is suggested anymore. You need to monitor a CO2 surrogate marker. As you all know, when you're doing PAP titration, you cannot use an end-tidal CO2. The PAP flow signal would dilute the CO2 measurement, and that would make it unreliable. So when you are doing titration, you have to use transcutaneous CO2. This slide is interesting because it tells you what untreated hyperventilation is going to do to many of our patients, and we've been seeing that through the morning. One of the important things for hypercapnia is that, of course, in a normal patient, that CO2 is going to increase between 2 and 8 millimeters of mercury. And that's depicted here. So here you have ventilation in liters per minute, and here you have CO2. So even in an awake person, the CO2 is going to start rising as we get into sleep. It's further decrease this ventilation in stage 2 and 3, and even more decrease when you are in REM. So that's why you're going to see many of our patients with OHS or COPD are going to get more hypercapnic when they are in REM. And this is not just to create confusion, but it's related to the chemoresponsiveness during sleep that is reduced from drowsiness all the way to REM sleep. And these are the consequences of untreated hypoventilation. So heart failure, pulmonary hypertension, increased risk of hospital admission, as we're going to see later, increased mortality also, as we're going to see later, headaches, sleepiness. So all these are things that we're trying to avoid by treating these patients. This is a little bit more of the hyperventilation broken into the way, I guess, most pulmonary physicians will see. So you have the elastic component of the lung that is opening the lung tissue, moving the air through the airways. So that's going to be the resistance of how the air flows from outside in the room to the actual lungs. And this keep it open is we've been talking most of the part of the discussion today is the upper airway, how we're going to keep it open so it gets there. So all those three components is what are part of the respiratory workload. And to treat hyperventilation, we have to think about all these. This is not OSA when we're mostly trying to keep the airway open. And that's what we're going to see the rest of the talk. We have to think about the airway resistance and then the lung distension. And as you see here, so here is what we talk most of the day, upper airway. So now we're going to talk about mostly these two components, obesity, hypoventilation, and COPD. We're not going to talk much about neuromusculars. Is something that is more complicated in general, is more related to diaphragmatic weakness. But most of the things that we're going to talk about OHS also apply to neuromuscular disease. There are other components that can also give to hypercapnia, which we're not going to talk today, which is, of course, when you have reduced central respiratory drive from opioids or congenital malformations in kids like Chiari. Muscular weakness, as we already discussed, poor ventilation from poor inspiratory effort. And these are other features of typically, this one would be COPD. This is what is known as the overlap syndrome. So these are patients that have upper airway obstruction and lower airway obstruction from COPD. These are also something that we might have some time, or if you have some questions, we can always talk about. People with COPD, they tend to trap air. That is going to hyperinflate the lungs, and that often can create problems with triggering the BiPAP that they could be using at home. So that's sort of an overlying of hypoventilation and hypercapnia in general. Now moving along into OHS, so we're going to start first with OHS. This is the definition of OHS. So now you need to have a awake PaCO2 more than 45 or a surrogate. Your BMI has to be more than 30. And which is very, very important, OHS is a diagnosis of exclusion. So you cannot have kyphoscoliosis and then call it OHS. So that's a kyphoscoliosis producing hypoventilation. So those are the things that you need to rule out: COPD, medications, central alveolar hypoventilation. Many of these patients ideally would need to have like a pulmonary function test to make sure that they do not have COPD. This is a little bit of the pathophysiology of OHS. So as we go through the night and we have a hypopnea here, the CO2 starts accumulating. Of course, it gets even worse when you get an apnea, then you have more accumulation. And during those brief episodes when the person is breathing, it's not enough to eliminate that CO2 that builds up. And here we have two phenotypes, which most likely you are aware. So OHS has two main phenotypes. One phenotype that is the CPAP responder. That means that as you treat these patients only with CPAP, they are going to get rid of that CO2 and they're going to do well. And they are the ones that are non-responders. Those are the ones that the CO2 load is going to accumulate and those are the ones that are going to get hypercapnia, drowsiness, and pulmonary hypertension. The first phenotype, the one that responds to CPAP, is the one that when you do your sleep study, the patient has both OHS, defined by elevated CO2 during the sleep test, but also has an AHI more than 30. And this is 90% of the patients that have OHS. So they do have hypoventilation during the day, and they do have severe OSA during the night. 90% of patients fall into this category, and these will respond to CPAP. There is 10% of the patients that they have minimal OSA, and they are the true hypoventilators. These are the ones that are not going to respond to CPAP because, as we're going to talk in the next few slides, CPAP does not improve ventilation. And these 10% of the patients, they have elevated CO2, that they have problems with ventilation. These are the ones that are going to need BiPAP devices, as we're going to talk in the next slides. This is a little bit more details, things that part of these things we've seen today. So here on this CT scan, you see the diminished upper airway before weight loss and how it opens up after weight loss. Here it comes to the part of the lung restriction. So you're going to see that the diaphragm is not moving because of the tremendous amount of weight that is preventing that movement. And then here you're going to see on a lean person how the lung volume is going to be bigger than in an obese person. And this is important because part of the treatment when we use NIV is to try to open up typically the bottom parts of the lungs in order to improve ventilation. Moving on into the clinical management on obesity hypoventilation, there is a relatively new ATS consensus about how these patients should be diagnosed. So when there is high probability of OHS based on the clinical features that we discussed, what is recommended is to do a ABG to see what the actual CO2 is, and as we remember, it has to be above 45 millimeters of mercury to make the diagnosis. When there is low intermediate probability, you can start, here's a mistake, you can start by doing a serum CO2, which is bicarbonate. And based on that bicarbonate, then that's what you're going to continue your algorithm. If that bicarbonate is more than 27, then there's a high suspicion for underlying OHS, and the patient will need an ABG. On the other hand, if that bicarbonate is less than 27, that is a low likelihood of OHS. That patient can proceed only to PSG because most likely does not have OHS. This is a little bit what we were talking before. Patients with AHI more than 30 and OHS, they are going to need mostly CPAP. And this is something that I guess when I started doing sleep medicine, it was still unclear. We didn't know how to treat these patients. So now we understand better that if it's severe OSA plus OHS, the first line of treatment is CPAP. And I'm going to show you in a few slides that there are clinical studies that were done that support this recommendation. The other important difference between OHS and OSA is that typically for OSA, we recommend patients to lose 10% of the weight in order to improve the AHI. Now for OHS, it's recommended a third of weight loss in order to improve ventilation. This is again more or less what we talk about, that losing 30% of the weight. And this is in the same document. I think in my opinion, this is one of the most important slides for when we do sleep studies and then we decide on what treatment option for the patients. So all these patients have OHS. This is the most common phenotype with elevated or severe sleep apnea, and CPAP is the adequate treatment. The ones that fail CPAP, of course, they're going to go to NIV, and the patients that have OHS with minimal OSA, those are the ones that are going to go to NIV. This is one of the randomized trials that came out of Europe, I think it's out of Spain, when they enrolled 200 patients with OHS and comorbid severe OSA. They followed them up to for 5 years, and basically they randomized to a patient with CPAP with NIV. Sorry, one group had CPAP, the other group had NIV. And they just followed them over time. And you can see on the graph here, which you can see the PaCO2 up to 5 years, the decrease in that CO2 is the same with either CPAP or NIV. The same with the pH. So they start with low pH, it increases as the ventilation improves, and it's exactly the same. The same with, here is bicarbonate, which is also elevated bicarbonate, as we already discussed, more than 27, is a marker of hypoventilation. And over time, CPAP and NIV are exactly the same. The bottom line, as we've been talking, that's what the recommendation comes from. In stable outpatient OHS that has comorbid severe OSA, the treatment is either one, but we all know that CPAP is easier and cheaper to use. So that's what the ATS said, is the treatment is CPAP, or should be CPAP. This is people with OHS that are released from the hospital, and this is probably what many of you have seen. This is not a series of randomized studies, unfortunately. This is just observational studies when the same groups in Spain went over and reviewed data of people that were admitted for OHS and were discharged from the hospital, 90% of them using NIV. And here we're going to start talking a little bit things that you know. So NIV means BiPAP SST of AVAPs. So that's what we're talking when we're talking NIV. Basically, as you see here, 3-month mortality is reduced with NIV. 6-month mortality is reduced with NIV, suggesting that people that are discharged from the hospital with NIV is reduced mortality following an admission for acute and chronic hypercapnic respiratory failure. Going into chronic OHS, again, non-randomized studies, 16 or 60% of these studies, patients use BiPAP ST. Most of this is coming again out of Europe. What you can see here is in chronic OHS treated with NIV. These are the physiological benefits, but also the clinical benefits. So because these patients have most of them have severe OSA, the AHI is going to decrease. The awake PaCO2 is going to decrease about 2.5 millimeters of mercury. Mortality, so BiPAP has lower mortality up to a quarter less at a year compared to non-PAP therapy. And all these other clinical markers are also improved. The recommendation is for treating these patients with non-invasive ventilation during sleep. Shifting gears to the other disorder that we're going to talk, now we're going to talk about COPD, another common reason for hypoventilation, and how you're going to see it in the sleep lab and how we are going to diagnose it or treat it. So the same hypoventilation diagnosis that we talked before, but here we need a lung parenchymal disease. So here you need a PFT. Of course, these will be other diseases is arise. So often we're going to see patients with heart failure. They're going to have pulmonary hypertension. So they can also have hypoxemia, probably not going to have, or they can have hypoventilation. But of course, each of these is a disease on its own. This part of the talk is only going to be about COPD-related hypoventilation. Oops. A little bit of the background of COPD. There are two major phenotypes. One that is on my left, which is about emphysema, where you see the lungs are totally hyperinflated, the diaphragms are flat, people are relatively lean, and they don't have, as it says here, a lot of OSA in general. They tend to have more hypoventilation. On the right, these are the patients that have chronic bronchitis. You see the lung size is not particularly elevated, but you're going to end up having more airway problems. So you're going to have more chronic bronchitis, more exacerbations, and these are the ones that typically are going to have OSA and COPD overlap. Talking a little bit about the COPD physiology. So we talk about these are the same three parameters that we're following. In COPD, there are more physiological problems in a sense that you have airway narrowing, air trapping, muscle weakness, and these patients, because they're constantly out of breath, their central respiratory drive is increased. More respiratory changes compare normal with COPD. There is muscle hypotonia, of course, when we're sleeping, and that is further increased in COPD because of the flattening of the diaphragm from elevated lung volumes. These muscles are very ineffective, and they have less function, 30% less in non-REM sleep and about 50% in REM sleep. Therefore, they're going to have significant hypercapnia that is worsened during REM sleep. This is a slide that tries to show how an overnight oximetry on the top will show hypoxemia. And this is what you're going to see typically in REM when the oxygen is going to decrease and going to stay lower for the duration of the REM period. And then what you see is a low baseline saturation. That is related to the underlying hypoxemia from patients with COPD. And here at the bottom, you see a PSG, when you're going to see that there is an apnea here, an obstructive apnea, but what is happening is the patient is trying to trigger the ventilator, but is not able to do that because there is so much air pressure on exhalation that is not able to trigger the ventilator. And this is why in patients with COPD or neuromusculars or even OHS, most of those patients are going to need a backup rate because it's going to be very difficult for these patients often, especially in REM, to trigger the ventilator only on BiPAP-S. Moving along with COPD, this is the overlap. We're not going to talk much about this because you're used to that. You definitely do the CPAP titrations without any major problems. The emphysema, as we discussed, you're going to have mostly hypoxemia. These are the ones that we're going to use ventilations with BiPAP. They might need oxygen bleeding depending on residual hypoxemia. And the bronchitis patients, that's the ones that typically have a comorbid OSA, and these are the ones that most likely are going to need CPAP. Now, there is also been some changes in the COPD literature that I'm sure you are aware, but you can see these are over the years, the studies that have been done in COPD patients with ventilatory support. Draw your attention to the earlier studies were done with low ventilatory support, meaning an IPAP pressure of up to 15. And again, those are the older studies. These studies, there was no proof or change in readmissions or mortality. The most recent studies that have been done after 2015, typically we're going to look at two, the Murphy and Condling studies out of Europe both. They showed that by using high intensity BiPAP or NIV ventilation, these patients with COPD, they have less readmissions and less mortality. One of the things that I guess I'm not sure how you've been doing this, these are the IPAP pressures that have been used. So an IPAP pressure median of 30, that's a way, way high pressure. but these are the pressures that these patients are going to need. so, so typically, I guess most of the sleep labs at this time, I'm not sure if they have been doing this, but those are the pressures that have been used, and we're going to discuss some of that. So this is the first study. It's an outpatient COPD survival on non-invasive ventilation. 1 year mortality, there was 12% in the NIV group compared to 33% in the control group. There is a risk reduction mortality of 24% at 1 year. And this is what you see. The control group has higher mortality, and the intervention group has lower mortality at 1 year. Which I think is very important, is a number needed to treat. So number needed to treat means that you have to treat 5 patients to prevent 1 death. Which by the study, as you know, sometimes the studies look pretty nice, but then when you're doing in clinical practice, that's different. But typically, this is a very low NNT. And we don't have, as far as I'm aware, a lot of treatments that can give you these outcomes. One of the problems, not the problems, but one of the new findings, so to say, is the IPAP pressures that are needed. So the mean IPAP pressure was 22 plus 5. And then in addition, they use backup rate. All this is trigger, or not trigger, but target to decrease the PCO2 by 20%. And the idea is to try to achieve values below 50. Many of these patients, it's not here, but many of these patients, in order to get enrolled in the study, the PaCO2 was about 55. So this has changed a little bit what we used to do, because we used to say COPD, they always hypercapnic, you don't need to change that physiology. Well, this is changes a little bit that thought, and the most recent algorithms are saying that we need to try it as possible to lower the PCO2, because that seems to be the patients that are going to benefit with reduced mortality, reduced readmissions. This is the next study that is on readmissions out of the UK group. The same here you see, let me see. This is the home oxygen plus NIV, and this is admission-free survival. So they have 50% less, 50% admission. And then the home oxygen group, it has only 20% hospital-free admission here. And that's what is shown here. 63% in the home oxygen group had readmission free survival, or an 80% of the home oxygen. I think I'm saying it wrong. Got it. So there is a readmission was only 60% in the group that had oxygen and NIV, whereas it was readmission risk 80% only with home oxygen. Again, the number needed to treat is 6. So very, very low numbers, suggesting that this will be highly efficacious to treat patients with COPD and reduce readmissions. This is this, another graph of what we saw in the graph. These are the initial studies. These are studies that were done as an inpatient, 48 hours after being admitted for an exacerbation. These were negative studies. They did not improve any outcomes, and actually they led to transient hypercapnia. These are the most recent studies. We're talking an FEV1 of 23%. So this is very, very reduced lung function. You can see most of these patients have a PaCO2 more than 53. And these are the patients that are discharged from the hospital, and they are evaluated in the sleep lab at 2 to 4 weeks after discharge. These are the ones, the study that we saw before, the Murphy study, when it showed reduced hospital readmission. This is a summary of what we discussed. Basically, the red are the ones that they show no benefit, and the green ones is the one that we discussed. These are the 2 studies that we saw this one reducing mortality, and this one reducing readmissions. So now that we clear most of the two main common conditions that lead to hypercapnia, I'm going to try to talk a little bit about ventilation for these patients in the sleep lab. So this is what we're all used to do before the home sleep studies were widely available. So we did CPAP mostly to open up the airway. There was no change in tidal volume, and there was no ventilation at all. So we're going to talk today is going to talk about BiPAP. So BiPAP, I know the guideline says that sometimes you can use it when the patient doesn't tolerate high CPAP pressures for OSA. That's perfectly fine. But the most indication when you're putting a patient on BiPAP is you're increasing the tidal volume. And yes, you have the EPAP that opens the airway, but you are doing ventilation basically. And the more BiPAP you use, you see you are going to increase the lung volumes, you are going to improve oxygenation, you're going to decrease hypercapnia. And these are the three devices or softwares, I guess, so you're going to use with BiPAP. BiPAP S, that is without a backup rate, BiPAP ST, which is with a backup rate, and AVAPS, which is basically an automatic self-adjusting BiPAP pressure device. And we're going to try to talk about many of them. So this is what we're talking. The ST, it does both ventilation and upper airway. The AVAPs, you probably know, there are two main brands and they have two different names. AVAPs is from Respironics and IVAPs is from ResMed. They have different targets that we're going to see, but the main goal is maintain stable ventilation. ASV, we are not going to talk today. This is more, as you know, for Cheyne-Stokes breathing for central sleep apnea. But it's mentioned here because it's another advanced BiPAP modality. This is in a graph what both AVAPs modes are going to do. The one here on the top is the one from Respironics. This device targets tidal volume, and you're going to set up when you do your titration in the sleep lab the target tidal volume based on ideal body weight. And then you're going to have an EPAP that it could be fixed or it could be APAP. And then you're going to give the device limits. One of the limits is IPAP min and IPAP max. And then you're going to let the device monitor this tidal volume, which as you see here is below the target. Then the device automatically is going to increase the IPAP until it reaches the IPAP max and until it reaches the target tidal volume. If this device reaches the maximum pressure and this tidal volume is still not to the target, the next setup would be to increase, not to increase, but to start using the backup rate from the device. This is the one from ResMed, which has a different target, which they go by the alveolar volume, but pretty much functions the same way. So you have an auto EPAP to keep the airway open, and then you have an IPAP minimum and an IPAP maximum, and it's doing the same. Whenever the alveolar volume is below the target, then the IPAP pressure is going to increase automatically. Here you see these black arrows. That's the backup rate. This is a good slide because this tries to combine what we would used to do before 2010 and what AVAPS is. So you see the red line or the red graph, that's plain BiPAP S. You have your EPAP, it goes to IPAP, maintains the IPAP pressure for the time determined, and then goes to EPAP. What you see, the blue line, this is the AVAPS algorithm, which you have APAP basically. The EPAP is automatic. And then you have the other two settings that you're giving your machine. You're giving a minimum IPAP and you're giving a maximum IPAP. And what is shown here, which is very important, and sometimes people get confused, the difference between the EPAP and the IPAP, that's your pressure support. So between these two lines, this is your pressure support minimum. Between this line and the maximum IPAP, that's your pressure support maximum. And the pressure support difference is very important because that pressure support is just going to give you the tidal volume. So if your EPAP is too high, let's say you put it here, your pressure support is going to be very reduced. Your tidal volume is going to be very reduced. So the pressure support is extremely important. And then here in the bottom, you sort of see the same, but we were talking before. This is a target tidal volume, so this is a respironic graph. Whenever the target volume is below the target, the IPAP pressure is going to be automatically increasing. And whenever you reach the target volume, the IPAP is going to go down and up and down, up and down. Here you see even the EPAP is already going up automatic because the device probably detected upper airway resistance. So it's a very automatic mode that it has many advantages depending on the side position. So you can imagine that when the patient is on the side, sleeping on the side, is probably going to need less IPAP. When the patient is in REM, is probably going to need more EPAP and IPAP. And you basically have both parts done automatically, and that's what many patients would need. Now, as of now, it's not clear if ABAPS is better than BiPAP ST, but you can see that there are advantages with automatic adjustment of pressures. As we all know, these are the two main manufacturers. Here it gets a little confusing. This is the ABAPS from Respironics. When you set up these units, these are the different modes that you can set it up. We will have time to talk about these because they make the machine work differently, but you can set it up in S, ABAPS S, ST, pressure control, or time. ResMed from that point of view is a little simpler because ResMed only has ST. And that has some differences when it comes down to creating synchronicity with the ventilator or with the non-invasive ventilator. As we discussed, Respironics targets the tidal volume. There is a backup rate, and there is auto EPAP basically. These are the RADs, respiratory assist devices for outpatient. These are the home ventilators, the Trilogy. This is a home ventilator, but it has a software where you can choose ABAPS. On the IBAPS of ResMed is a different target, as we discussed. It has a backup rate, and it also has APAP, and these are the RADs, and this is the home ventilator. This is what we were talking. So this is straight BiPAP. This is your EPAP. This is your IPAP. This is your I time. I time stands for inspiratory time, so how long the inspiration is going to last. This will be your cycling. We're going to talk a little more in the next few slides. So cycling is when the ventilator or the BiPAP goes from inhalation to exhalation. And this is what we were talking. So here is the pressure support. The wider your gap between the EPAP and IPAP, the higher your pressure support, the higher your tidal volume. And again, we're talking that these patients need ventilation. So most of the algorithms are going to tell us that the gap between IPAP and EPAP should be at least 10 centimeters of difference. If it's less than 10 centimeters, the tidal volume is going to be very reduced. Probably you're not going to be able to get rid of any CO2. Building into this setting up of the BiPAPs, I think this slide is very, very important, and this is what we were talking. So this is the trigger. This is what is called the rise time. The rise time is how fast the air goes from exhalation to inhalation. This is important, as we're going to see in the next slides, because the COPD prefers different rise times that obesity hypoventilation. Here is the cycle that we discussed is when the BiPAP changes from inspiration to expiration. And this is what is very important. This blue area, this is your tidal volume. So here is the first time when you start seeing what are the determinants of the tidal volume. So one we already discussed, the pressure support. So you need a gap between EPAP and IPAP of 10 at least to generate tidal volume. The other important determinant is this. This is your inspiratory time. So if I put this inspiratory time here by half, this tidal volume is going to be cut off by half. On the other hand, if I make it longer, then the person is going to have longer tidal volume. And those are the two variables that you're going to need to adjust when you're doing BiPAP for OHS or COPD. Your IPAP pressure and your I time, or your inspiratory time. Now these slides is a little complicated, so I'll try to make it a little simpler. And this is what is related typically to the different brands of AVAPs. The Respironics device, when you set it on AVAPs ST, ST means that there is a spontaneous breath and a time breath. And Respironics treats each breath differently. So this graph here on the left, it has two breaths, and one, the number one is triggered by time. So you see here time cycle. So this is what is called the time breath. So in Respironics will be the T part. The number two is the one that is cycled by flow. So this will be the number two here that is a little later. So when you put AVAPs on Respironics under ST, Respironics is going to treat your own breath as a flow trigger. And the machine breath is going to be triggered by time. So it can be confusing when you are doing the titration if you have a Respironics device, because if you put it on ST, you're only going to get the I time attached to the breaths that are triggered by the machine. And when the patient is triggered, or triggering the patient himself, that's triggered by flow. And that's different because flow is effort dependent. So it's variable, whereas time is based on time. And that's what ResMed does. So this would be a ResMed device, which from that point of view is simpler, because here all the breaths on AVAPs are time cycle. So if you put a 1 minute of inspiratory time, all the breaths are going to cycle after 1 minute. So you see here go from EPAP to IPAP. Sorry, no, it's not 1 minute, it's 1 second. Then for 1 second, that breath is on inspiration. Once you reach 1 second, exhalation starts. And you see here the flow is the same. It doesn't change because the flow is constant and you're cycling by time. The Respironics device, it depends. This number one is the machine breath. This number two is the effort breath, that is the patient, and the flow changes. So I think it's important that when you're doing your titrations, you know, first of all, which brand are you using? Are you using Respironics or ResMed? And second, you need to understand a little better what the time, inspiratory time is, and to which breath is being applied. And this is when we start trying to adjust some of the different parameters to different diseases. So for example, in an overlap syndrome, which is COPD and OSA, you want to have a low rise time, pretty much to try to, so when you have a reduced rise time, basically that will be this black line. You are going to make your inspiration short. And you need or want in COPD a short inspiration so you have more time for exhalation. Now, on an OHS patient that behaves as a restrictive patient, then you have an increased rise time. So it's going to go up slower, but you are doing here, you are increasing your inspiration. So in a restrictive patient, you want to prolong the inspiration. In a COPD patient that is obstructive, you want to reduce the inspiration. And by doing that, you are prolonging your expiration. So you give it more time to empty the lung. So that's as regard the rise time. This is as regard the inspiratory time. We already talked that this inspiratory time of half a second, 0.8 seconds, 1 second is going to be a determinant of the tidal volume. So you see here in an OHS patient that is restricted, you want to give him more time to open that lung because the lung, it has hard time opening. Whereas in a COPD patient, you want to give it a short inspiratory time. So by shortening the inspiration, you prolong the exhalation so the lung has opportunity to empty. So here's when you start customizing different parameters that you do your titration or when you're seeing patients in the clinic based on the disease. Both are going to have hypercapnia, but as you can see, they behave differently. This is what we were talking before with the Respironics device. So you see this is inspiratory time. So you set the inspiratory time. Let's say this is 1 second. Once you reach 1 second, then the device automatically goes to expiration. If you are with the Respironics device and the patient takes its own breath, now it's going to cycle by flow. And this is what I was talking before. The flow is effort dependent. And it also depends on which disease, how you can set up this flow. So a short flow, like this one here, is the one that is going to help COPD patients. Because if this flow is short, that means inspiration is going to be short. If you let it go lower and you cycle at this level, this flow is going to be longer. Your inspiration is going to be longer. So this is going to be more for OHS. So you can see that this would be part also of synchronizing the patient to the device more accurately. This is a little bit more of what we were talking. You can also adjust the trigger sensitivity. This is typically more for neuromuscular patients. So a neuromuscular patient, you want to make the trigger very high. So very high means that it's very sensitive. As soon as the patient makes effort here, then the device is going to trigger. The cycle, we already talked. And here is more or less what we were talking before for different diseases like neuromuscular. For example, neuromuscular, you want the cycle sensitivity to make it very low here. So you see this flow is going to drop and it's going to last longer, and inhalation is going to be prolonged in a neuromuscular patient. These are some of the devices, the adjustments that are suggested. In OHS, you want to prolong the rise time. We discussed about that because this is a restrictive lung disease. The opposite in a COPD, you want to make that rise time very, very short so patient has time to exhale. In neuromuscular, we discuss increase the trigger sensitivity and prolong your I time. These are things that you might hear from your patients mostly in the clinic. Do you feel that the ventilation basically follow you, that you are trying to trigger or you're trying to take a breath and you can't, so you can adjust the trigger. The rise time is, as we discussed, how fast you're going to get there. So is the ventilator give you a blast of air, then maybe you need to reduce your rise time. Is your breathing cut off earlier, then you need to adjust your cycle sensitivity if you're doing it by flow, or your inspiratory time if you're cycling by time. This is a summary of inspiration. So here's your inspiratory time, the ventilator cycle. This is exhalation, and the cycle goes on and off. This is the flow, your inspiratory time, your expiratory time. Normal, the relationship between inspiration and expiration is 1 and 2. And this is what you want in different conditions. So in restrictive disease, you want to increase your inhalation. So that's what now your inhalation is prolonged. In obstructive disease, you want to shorten your inhalation, so you prolong your exhalation. And that's going to be important when you set up patients, because depending on which device you're using, you can see that based on whatever rate you put and whatever disease you have, you are going to have the inspiratory times that you're going to set according to these respiratory rates. This will be for Respironics. This will be for ResMed. How to adjust your inspiratory time. So as you know, all these algorithms, very important that you have a good mask fitting. If there is a lot of leak from the mask, all the parameters that we discussed are going to be affected. There is going to be problems with the trigger. There is going to be problems with the cycling. You're going to lose pressure in the system. And potentially what you're going to have is something like this. This is a download from a patient on AVAPs. As the leak goes up, which here is the leak, 40, 48, 85, the IPAP is increasing to try to compensate the loss in the pressure. The tidal volume is decreasing, and your minute ventilation is going down. So very, very important to keep working on mask fitting. We're going to skip this one because it's a little complicated. This is a little better, I think. Basically, as we says here, this is the goal of non-invasive ventilation. As we saw in the prior clinical studies, what we're doing is trying to decrease the arterial CO2, which we see here over time at 6 months. We are trying to increase the pH as a consequence. The oxygen is going up here, and then the bicarbonate is going down. This is for a COPD patient, but you see here is this is on a spontaneous breathing, so no respiratory support. And this is basically the pressure in the esophagus that is reflective of the effort that the patient is making. When you apply low BiPAP pressures, you see the flow is here. Now the pressure is higher because now you're giving a positive pressure. The esophageal pressure is reduced because now the BiPAP is assisting the patient in breathing, but they're still making effort. But when you put those patients in high BiPAP pressure, as we were talking, IPAPs of more than 18, you see that the diaphragm is potentially resting. We're going to move to some of these slides because I want to show you this, which is important as regards how you're going to adjust your AVAP settings when you're doing the titration at night. So one of the things, the first is you're going to see if you are reaching either your alveolar volume on ResMed or you're reaching your tidal volume on Respironics. We know that the tidal volume target is 8 cc's per kilo ideal body weight. Next thing is you want to see the respiratory rate. The respiratory rate is a marker of ventilation effectiveness. If your respiratory rate is too elevated, that most likely means that your ventilation is insufficient. And then you potentially could calculate something that is called rapid shallow breathing index. This is not unfortunately shown in randomized trials, so this is more in cohorts of patients, is more used in the ICU. I don't know if there's any respiratory therapies. We use the rapid shallow breathing to predict successful extubation. But basically, the lower your shallow breathing is, the better ventilation you are doing. And the goal of the rapid shallow breathing is less than 40. And that I'm going to show you in the next slide. So basically, when we're doing non-invasive ventilation, we are trying to reduce the work of breathing. So you see this line is the total work. This is the tidal volume, basically, elastic work. And this is your airway resistance. And you see that the less amount of work is when you have higher tidal volumes and lower respiratory rate. So when we were seeing in the prior slide, monitoring your respiratory rate, if it's elevated more than 15 or more than 16, that means the patient is working too hard. That means you need to adjust your IPAP parameters or your I time. How am I doing on time? 5? Okay. And this is how you adjust it. So basically, you need to continue working on the tidal volume. So 2 things, pressure support and I time. So what we need to find out is we need to find out the average IPAP and the 95% IPAP. The average IPAP is going to be your floor. And the 95 percentile is going to be your ceiling. And that's going to give you very likely elevated PS or IPAP pressures, but that's what you need to get to your target tidal volume. Is that not enough? The next thing that we discuss is increasing your inspiratory time. You can expand your inspiratory time to 1.2 seconds. In ResMed, typically they have a range of ITI times, so they give you TI mean and TI max. So you definitely want to do your TI mean 1.2. In Respironics, there is only going to be a TI, so it's going to be 1.2. If this is not enough, this is when you need to adjust your backup rate in order to achieve your target tidal volume or alveolar volume. This is a summary. This is a summary of what you do when you do typically the AVAPs down low. So you see, very important to check for leaks. Is the patient reaching the target tidal volume or alveolar ventilation? You look up for efficacy of your parameters. Are you at the target tidal volume? Is your respiratory rate low? Is your rapid shallow breathing less than 40? If it says yes, then you monitor. If it's no, these are the things that we discuss. You keep increasing your range, you keep increasing your I time. I think that the next few slides are going to be related to the Medicare, and then after that we're going to stop and we're going to take questions. So last year was published in CHEST, the panel that is related to optimal non-invasive ventilation suggestions to Medicare. As we discussed before, this is a suggestion of experts in the country. Medicare has not made any major comments about this, so it's unlikely at this time that it is going to be approved, at least this year. The experts suggest no longer have measurements of CO2 while patients are on prescribed oxygen. And again, this is for OHS. This part is for OHS. They're also suggesting the elimination of doing the sleep study that at this time needs to be done in order to qualify the patient for a BiPAP device. It's also, the current recommendation is to do a spirometry to make sure the patient doesn't have COPD. And it's also recommended that at this time that patient has to fail BiPAP S in order to get access to the BiPAP ST or AVAPs. And as you can imagine, that's creating a lot of delays. We're going to skip these ones, and this is the one for COPD, the same group, the optimal NIV Medicare abscess promotion. So they are suggesting to remove the requirement that the oxygen has to be less than 88% for at least 5 minutes with the current FiO2, and then that the patients, again, have to use BiPAP without backup rate for at least 2 months, and then that you have to prove that that device is not helping before you get a backup rate device. I'm going to stop here, and I'm going to take questions.
There's one question, and it is, somebody says, I am getting confused between ASV and IVAPs.
Excellent question. Excellent question. And that's what I was trying not to put ASV, but it's impossible to change the slide. So what we're talking is we're talking non-invasive ventilation, and that's related to BiPAP with different modalities. So that's BiPAP S, BiPAP ST, and AVAPs. So that's what we're talking, non-invasive ventilation for hypercapnia. ASV is adaptive servoventilation, is another type of BiPAP, but that does not treat hypoventilation. That's a device, ASV, that is designed for central sleep apnea. So that's for irregular breathing pattern. And that's typically for heart failure with chain-stocks breathing. It can also be used for central sleep apnea related to opiates. It can also be for treatment, emergent central sleep apnea. But the ASV is for the breathing pattern. So that's a separate talk. What we were talking today is hyperventilation with hypercapnia.
I just had one quick question, and that was in ALS patients. What's the best way to handle them? Do you bring them into the lab for all-night titration with TCO2 monitoring? Because we're treating them with the IVAPs or AVAPs to assist their breathing because of their muscle weakness?
Exactly. And that's a good question. Most of the clinics for ALS specifically, they can get to an AVAPS device
Without a sleep study.
without the sleep study, assuming clinically that you don't have any major risk factors for OSA. And the advantage of the AVAPS specifically for ALS and most of neuromuscular diseases is that it's a progressive disease. So the needs are going to change with time. So if you put a BiPAP that is a fix and it cannot adjust with time, that's going to be a detriment to the patient.
Well, thank you very much.
Very welcome.
Very interesting. If